Hello, and welcome to the Houston Methodist Heart and Vascular Tele-CV Education series revolving around digital health and telemedicine. My name's Ahmed Soliman. I'm a cardiologist here at Houston Methodist. Over the last few months, as we have been living through the COVID-19 crisis, a major pandemic that changed the world in what feels like an overnight storm, many things changed dramatically, including our communication with our patients, as well as management paradigms. These continue to evolve in a very quick way. Clearly, the world went virtual overnight. It was interesting to see that many learned and adopted very quickly what some of us have been advocating for many years. The value of telemedicine is well demonstrated nowadays. This is not limited to the practice of medicine, but also to the practice of cardiovascular disease. Those of us that have been practicing and trying to advance telemedicine for a while will tell you how an uphill battle it has been. This COVID-19 pandemic was a great opportunity to open doors that have been locked for a very long time. And here we are. The implementation of telemedicine has taken off faster than any of us would have imagined, in circumstances none of us would have wished for. But it's now out of the box. The recent past will very soon feel like the distant past. There will be a new normal for the practice of medicine. There's always something good in everything. The goal in this series is to discuss and understand the implementation of telemedicine well beyond the current crisis. To learn this from physicians with expertise in digital health and telemedicine, administrators and industries that have been in this for a while, have been and will continue to be a major impact on leading us through to provide more efficient care, how to adjust the financial aspect of this care, how we retrain the current and train the future generation of cardiologists not just to provide this type of care, but to innovate through digital medicine. Cardiologists have the opportunity and should be at the forefront of how things will be changing in our practices in the very near future. Today, I am pleased and honored to welcome two very special guests today. I'll present them both and then we will start with their presentations. Dr. Heba Wassif. Dr. Wassif is a cardiologist at the Cleveland Clinic, trained in both general cardiology interventional at Johns Hopkins. And among many titles and responsibilities over the years, the most impressive in my opinion is that she is a long-time telemedicine digital health avid cardiologist. She has been advancing the field through multiple programs and grants over the years. She is part of the leadership in the Healthcare Innovation Council at the American College of Cardiology and is co-chair for the Digital Health and Devices Work Group. Welcome, Dr. Wassif.
Thank you, Ahmed, for this introduction. I'm delighted to be here. And this is certainly it's a very difficult time, and we did not wish that digital health be advanced in this way, but here we are.
Yep. Our next guest is Dr. William Downey. Dr. Downey is a cardiologist in a very beautiful part of the country, in my opinion, at Sanger Heart and Vascular Institute in Charlotte, North Carolina. Trained in both cardiology and interventional at Mass General. Among his many titles and responsibilities, he is the Vice Chair, Quality and Care Transformation and Medical Director at Sanger Heart and Vascular. I had the opportunity to attend the CV Summit in February of this year, which, by the way, I would highly recommend if it is held next year to attend. And I had the opportunity to listen to him in two different sessions regarding clinical integration and telehealth. Welcome, Dr. Downey.
Thank you very much, and thank you so much for organizing this so that we can take this unexpected and unfortunate opportunity to really learn from each other. So thank you.
My pleasure. So I would recommend everybody not just listen to these two very special guests today. Get yourself a pen and a notepad, or electronic notepad for that matter. This will be worth it. I would also like to point out if you may send any questions at any point to text it to DeBakey. Text DeBakey to 37607 or send online to pollev.com/DeBakey. We will start with Dr. Wassif first in regards to physician adoption. Dr. Wassif.
There we go. So thank you, Ahmed. So I'd like to talk about physicians' adoption. And this is, I have no disclosures in regard to this talk, Over the coming few minutes, I will be describing the technology adoption life cycle. I want to discuss physicians' motivations for adoption and provide case use examples, one of them pre-COVID and some post-COVID. But before we do that, I'd like to go to the very beginning with one of our very early innovations, with the stethoscope that seems part of our traditional care today, and we don't think twice about it. But when it was invented in 1816 and came to use by 1819, the early 19th century, a group of American physicians who were studying in France at the time were introduced to this new technology and brought it over to the US. However, the process of adoption was very, very slow. The majority of practicing physicians in the US at the time were in rural areas, and most of these physicians were in the Northeast. And it took over 90 some years to adopt this technology, up to the extent that Osler in 1903 said, "It's shocking to say, but you all know it to be a fact that many, very many men in large practices never use a stethoscope." So what were the barriers for adoption? Well, some of these barriers were investigated by Reinhardt, who reviewed a lot of the literature and medical books and medical curriculum at the time, and came up with these three major elements that he felt to be barriers for adoption. One was lack of formal education and opportunities for continuing medical education, particularly for physicians who practice in rural area and clearly at that time did not have exposure, not as we have it these days with all these technologies that connect us. The complexity of the interpretation of these auscultatory findings that were recent, and a lot of physicians were not able to integrate them and understand them, as well as the hesitancy to change from traditional medicine, where patient and physician were very close, and to introduce an instrument in between. And this theme is very common and will be heard throughout this presentation. We move on to the 1960s with Everett Rogers and his classic work of diffusion of innovation. He described the diffusion of innovation as a process by which innovation is communicated through members of society over a period of time. And those members were described in a bell-shaped distribution, and as we can see, it seems very familiar. We can even put names on some of these categories. So it ranges from the innovators, who are highly motivated, very resourceful individuals, risk takers, the early adopters that have similar qualities as the innovators, but the difference is that they have leadership qualities. They're capable of creating change. They can move things along and propagate the innovation. The early majority, somewhat pragmatic, somewhat reserved, but are willing to adopt if you provide them with a service or a technique that provides value to them. And the late majority will follow with the early majority. And of course, we end up with the laggards who will never change, regardless of whatever you produce to them. So those are the individuals in this adoption cycle. But what about the different factors that affect adoption? We always talk about implementation, but we don't talk about adoption, where adoption is part of any implementation process. And this work from Jennifer Wisdom et al. Reviewed had an intensive review of the literature and different frameworks in regards to implementation of innovation, and came up with this very complex construct and framework, which is multi-layered, as we can see, for the factors that impact adoption: external factors, organizational factors, factors related to the innovation process, the innovation itself. And I'd like to focus on the individual factors. What motivates individuals? What makes them ready for change and the capacity to adopt? And it's understanding these factors that would allow us to cross the chasm from the early adopters to the early majority and move on with our innovation. So this question is like, what motivates physicians? So the AMA asked that question twice, in 2016 and 2019. And the question was in regards to a very broad spectrum of digital tools. Some of them are very familiar to us, remote monitoring for efficiency, meaning blood pressure monitoring, ambulatory blood pressure monitoring, absent devices for chronic disease management, clinical support systems, also for chronic disease management, patient engagement, and telehealth, which is the hero in this conversation. Point of care flow enhancement, communication among physicians, and consumer access to clinical data such as MyChart and so forth. And with this very broad clinical, digital clinical tools, they ask that question: what motivates physicians to use these digital tools? And clearly, the number one factor that motivates physicians, because this was a mixture between primary care physicians as well as specialists, it was efficiency. It had to improve efficiency. Secondly, it increased safety, improves diagnostic ability, reduced burnout, particularly for younger individuals as well as women, improved patients' adherence and its convenience, and it also maintained the patient-physician relationship, the traditional relationship that we've talked about. So what were the requirements to adopt these digital tools? And some of these themes are familiar to us, that it be covered by malpractice insurance, integrated into the EMR. Reimbursement, interestingly, was not a priority in this particular survey. Also, additional factors, some factors related to the individual, that it be as good as traditional care, that it's safe, and it's simple, does not require any special training. And from there, I moved from my own experience at the Cleveland Clinic, where some of these factors were mitigated, such as coverage by malpractice insurance, a semi-integration in the EMR record, and that's pre-COVID. The reimbursement was primarily out of pocket. And in spite of that, and in spite of the exponential growth of our digital health visits across the enterprise from 2014 to 2019, only 20% of providers accounted for 85% of virtual visits. So the Heart and Vascular Institute wanted to cross the chasm and improve our adoption for this technology. And the way to be able to cross the chasm was assembling a diverse group of physicians, identifying a champion physician in each section to represent the members. And this champion was responsible for surveying each section and their needs and their processes. For example, in my section, the clinical section, we identified that our post-hospital discharge was no-show rate was about 20% compared to 5% in other divisions. And we wanted to target that particular area by using virtual visits. The champion also had a role in facilitating training and demonstrating the ease and the use of the technology. But COVID-19 took us by surprise. And within the first quarter of 2020, our number of virtual visits almost approached the number of virtual visits throughout 2019. And we're expected to continue to see that rise. On a national level, though, excuse me, from the Innovation Council standpoint, we were interested in understanding how prepared physicians were when they were surprised with the COVID-19 pandemic and how that impacted their practices. And so we conducted a survey through the ACC digital, from the digital website. And we asked, and we have 342 respondents from a very wide, broad variety of practices across the US, over 300 in 42 states. And 90% of respondents said that COVID-19 has pushed their organization towards telehealth sooner. And only about 14% were using telehealth previously. And that was not much different from the national average, where in the AMA survey, about 28% were using it. And physicians adopted very quickly. They were willing to provide the services in any way, shape, or form, whether it was integrated in the EMR or not integrated in the EMR, as well as how they would provide the service, whether it's from home or from the office, from a laptop, from a desktop, from a smartphone, in any form. And there was a wide spectrum of which digital tool was to be used. And of course, we talk about barriers, and barriers were asked during the survey, and reimbursement was the number one barrier for not advancing with telehealth adoption. Some of the comments that we have heard was liability. Physicians were concerned about outcomes. At the same time, also the concern about bonding and trust that needs to be established and is better established through a face-to-face visit, traditional care coming up again. So where do we move from here? And as Ahmed had mentioned, training. I think it's very important to proceed with telehealth training in our medical schools, which is already happening. And at least 60% of medical school are providing some form of introduction to telemedicine across the US. So the take-home messages from reviewing all these case uses and so forth, that adoption is not a top-down process. Physicians want to be involved. They've always wanted to be involved. Respondents, over 90% said they wanted to be involved. To underline the motivating factors and the barriers for us to be able to overcome the chasms, identifying a clinical champion to assist in the process, medical school education, and hopefully not waiting for the next pandemic to promote innovation.
Thank you very much, Dr. Wassif. I think it's clear that physicians that thought in the past that they would not want to do this or really cannot do this found out very quickly that they can and they actually do want to do this. So Dr. Downey will discuss with us and explain to us what his practice went through over the last few months. Dr. Downey.
Wonderful, thank you. And thank you again for organizing this. Perfect. So we were in a fairly different place. First, a little bit about Sanger Heart and Vascular Institute. We're 37 practices encompassing adult and pediatric cardiology with cardiac surgery and vascular surgery, as well as pediatric cardiac surgery, comprising about 300,000 visits a year among more than 220 providers. And prior to March 15th, more than 99% of our visits were face-to-face. We had some very rare telephone visits in our heart failure clinics post-discharge, but it was very close to 100% face-to-face visits. As COVID came, we realized we had a problem. We've got 300,000 annual visits that are going to get, should get shut off for the safety of our system and for the safety of our patients, recognizing the extraordinary mortality rate for the 80-year-old patient with heart failure who might get COVID in our waiting room. We realized we had to change something essentially overnight. We began working on a telehealth strategy on a Monday afternoon, had it in trials by Friday with one platform, early trials with one provider, and some education and working on standing things up. But that Thursday, before we began the trials, we made the decision that we would be closing our offices on Monday to all face-to-face visits. So we basically had from less than 7 days of total, total days to transition from 100% in face-to-face to 100% not face-to-face. And it's remarkable how quickly you can change when you say you're closing down your traditional way of doing it. Things that supported that were, one, we confirmed that our liability coverage carried us through both telephone and video visits, so there wasn't a liability issue. As we all felt the waves of regulatory changes, but the regulatory apparatus of CMS and our other commercial payers was evolving very rapidly. For us, in the middle of that week, Blue Cross Blue Shield said that they would establish pay parity for both telephone visits and video visits with face-to-face visits, meaning at least for one of our major payers that became a non-issue. And we thought, one, it's the right thing to do, and likely other payers, including Medicare, will hopefully come along fairly quickly. Our system gave support to our practices by saying, for the time being, we've got your back, do the right thing, and we'll figure out the reimbursement later on, but keep seeing patients. It sort of let us lead the regulatory changes, skate to where the puck will be, rather than waiting for the puck to get there. From a individual provider workflow adoption, we really didn't offer much of a choice because we said we're closing our offices. So that whole adoption cycle of early adopters and laggards almost didn't matter because, well, you have to go to work on Monday and now your work is at home. And we will help you, but here's what you got. So that it didn't feel very comfortable for many of us. I would say it felt quite uncomfortable for almost all of us, but there was certainly not much of a question of adoption. We couldn't have 20% adoption because we were seeing 100% of our patients that way. But incumbent upon us leaders was to actually make that feasible, to simply say, we're closing your office, you have to do something different, and that something different doesn't provide a platform on which to provide the quality and efficiency of care that you're used to providing, would be, criminally irresponsible, to be honest. So we spent, and a small team spent a lot of hours, one, testing platforms, but two, creating all sorts of auto texts in our EHR and making the documentation process in the EHR as much like the face-to-face visit as possible. We created new billing codes that looked exactly like the old billing codes and were parallel on the screen, except they were in a virtual column. If yesterday you clicked the one on the right, now you click the analogous one on the left, and we'll work through not the physicians, not the other providers, but the back office staff and leadership will work on creating a workflow where we figure out what those bills mean later. Just tell us what you did. So we made it pretty easy to provide the care that you wanted. At first, we didn't have a video platform that we felt comfortable rolling out to everybody. So we said, provide your care via phone visits for that first several days. We canceled a number of appointments to cut back on the number of visits so that we could validate the workflows, and then identified a few potential early adopters who on that very first day ran through video visits with a platform. By 2 o'clock in the afternoon on that first day, it was apparent that the platform that our system had used for urgent care and seemed like the one we already owned and the best thing to use was simply not going to work for our patients. It was actually just fine from a provider viewpoint, but for our office assistants, getting our patients set up on the platform via email with our office assistants now working from home, the patients with varying degrees of technical savvy, as all ours do, and frankly, our office assistants with essentially no prior coaching on how to coach the patient through the process, we realized that our current platform was just too cumbersome to get the adoption that we needed from patients. We also saw that we really needed to quickly get to video because at that point, we didn't think that we would be where we are now, where there's at least temporary parity for most payers with telephone. we felt like in order to get reimbursement, we needed to move very quickly to video. So here's sort of a graph of our transition. If you, this is pre-COVID over the year. The blue is new visits, the orange is return visits, and whatever amount of virtual visits in gray and yellow is too small to show up on the graph here for these weeks. Within, however, that first week, first days, we pre-transition, we cut back on our visits and began doing a little bit of telephone and video. When we closed down, except for some urgent visits, we moved quickly to telephone with a tiny bit of video, really just testing the platform. But in doing so, maintained over 45% of our total expected volume on a weekly basis, which we thought was pretty good. And then over time, added video so that now of our total total visits, video is now more than 50% as of last week. There are still a sizable number of telephone visits and a few face-to-face visits, which are beginning to grow back as the local guidance on businesses opening and is loosening a bit. But this was really our very rapid adoption of telephone followed by video approaches. Really for us, the key driver was making this easy for the patient, easy for our office staff, and easy for our physician, because if it's not easy, it's not going to work. And I think it was really critical that we stressed over and over that we don't expect our physicians to be IT experts. They need to be medical experts. And this is a tool for them to use like a keyboard, not something that needs to get in the way of the care. And we worked really hard to make that come as true as possible, though in a rapid transition, clearly there are hurdles, and we tripped on a number of those hurdles. But at the end of the day, we simply got to a decision tree where our office assistants could call the patient, say, do you have a smartphone or a computer that has a camera on it? If the answer is no, you get a phone visit. If the answer is yes, we give you a video visit. We moved fairly quickly to doxy.me as an easy button for us where you can send the patient a text. All they have to do is receive a text and click on it, and they are good to go. I think there are other platforms that work equally well. That's simply one that we arrived at that has worked well for us in this rapidly evolving environment. I think there's been an incredible amount of innovation by a lot of these companies that's been really helpful to us. And who knows if the platform we're using today will be the platform we use in 3 months. Our current workflow is then such that now 30 minutes prior to the appointment, our medical assistant calls the patient, does the medication reconciliation, asks the patient to check their own vitals if they have the capability of doing so, and confirms that the patient is in the provider's virtual waiting room, so that then I come up and the medications are already done and the vitals are already done just as they would if the patient were in the room. I do the video visit, document off to the side. This is not integrated into our EHR. It's through a web browser that we put up on a separate screen from our EHR, but has worked relatively well. It was, we have felt like being HIPAA compliant was important. I realized that for the time being, those regulations have been relaxed, which has helped enormously, but we don't expect that laxity to stay for the long term. And to the extent possible, we wanted to quickly get to something that was HIPAA compliant and could be relatively stable for us if possible. So the platform we've chosen is And what was really, we discovered very quickly, is our patients at least struggled with opening links out of email. They got confused about which email it was going to, and it turned out to be more cumbersome than I would have expected. But the text link works very well, and the scripting we've given our office assistants is to tell our patients to ask them, do you FaceTime with your grandkids? Well, this is pretty much like FaceTime. If you can do that, you got this. And that, instead of talking about virtual visits, if you talk about FaceTime, people relax a lot and it works much better. One of the nice things we've liked about the platform we're using, and I think others do this as well, is you can have multi-party video calls so that you can actually have patient and their family who themselves aren't in the same place, but to have difficult conversations about procedures, end-of-life care. You can have everybody on one call, and I think the communication is it can be outstanding. In addition, you can share your screen, and so we've each created a number of diagrams and things like that, where I think actually my patient education may be better than it is with the poor drawings I often do in the patient room face-to-face. Here I can use my mouse on some documents I've made for PowerPoints or other reasons, for example, my last case today, showing them what a PFO is and how we would talk about closing it, at least as well as I do face-to-face. Again, we talked about really trying to make it easy as possible so that using our standard office note that everybody's used to using, we needed to have some legalese in there. So we created auto text that said that the patient consented, that we did what we were supposed to do, that we're licensed in the state where the patient was, et cetera, and then documented the time. But this was really, we don't expect the providers to know this. We just created an auto text and said, fill in these 2 blanks and you're good to go. We also created these new internal codes for our visits so that we could then on the back end crosswalk to figure out, you don't need to stay with the changing policies of payment. Instead, you click on something that looks like the code you're used to clicking on for a given office visit. We'll figure out later what bucket it's going to fall into for a given payer. In short, telling our providers, you provide the care that is your job to provide. We'll try and make the technology a facilitator of that, not a burden to that. And I think thus far it's worked pretty well. I put up here some patient feedback because one of the things we did was put in extra patient assessments and provider assessments so that we got, overwhelmingly people have been thankful that it was safe. But also I've heard multiple people saying they never want to go back, including patients would have been very surprised at. It's been easy, and they've said, it was really nice not to have to get in my car and drive an hour to see you for 20 minutes. Instead, I'm here in my kitchen. I must say, as a provider, I've really enjoyed and I think learned from the entree we get into our patients' homes by seeing what's in the background. And I think it adds a nuance to the care that we provide. So I think, there are some silver linings in these clouds. There will be, more difficult transitions to come. I don't think we are at the final place for this. I think we clearly have more road to go to a place where we are 100% video. But I think there is zero question that this will be a lasting part of the care provided. When we did none of this on March 15th. I think that probably sets up hopefully is a good opportunity for a conversation. And I'm really interested in what other people have learned, barriers they've seen, how they've gotten around those barriers, et cetera. I think one other piece I wanted to share is training 222 providers simultaneously when they're all at home is not so easy. And one of the things we did to get around that was rapidly produce training videos in PowerPoint that we pushed out, and they showed click on this, very simple, less than 5-minute videos that you could watch and teach yourself how to do it. That was also not something we had rolled out previously. Our IT people would take months to come out with videos and this and that. Instead, us doctors put them together with a few administrative staff. We're not going to win any Academy Awards, but they got the job done.
Thank you very much, Dr. Downey. Actually, that is very similar to my experience also. I finished fellowship in 2018, and then I started telemedicine a few months after I started practice. I also trained here at Houston Methodist. And I remember for the last year or so, it's been trying to get people to at least try a few visits via virtual care or telemedicine or so forth. And then just out of nowhere, spring break came along, and it was, where are we? We need to do everybody. And by the end of the week, everybody's on board just out of nowhere. It's interesting how, and then now when you talk to any of my colleagues right now, they love it. And they're very comfortable doing it, and they feel that it's a lot more efficient in most cases. Obviously, it's not in 100% cases, but in most cases it is. So, Dr. Wassif, if you don't mind me asking, in regards to physician adoption, there's always a question about patient culture. So this is a culture change for physicians, but it's also a culture change for patients. I'll tell you, over the last year and a half since I've been working doing telemedicine, and it was cash pay, so most of the patients that did not want to do telemedicine was because of the payment. Again, it's almost less than 10%, but some of them were like, why would I come in? Why would I do this virtually? How is it that you would not examine me, and how would that you provide me care? How, or what do you see in regards to tools to help patients understand that this is a culture change, but we're still offering or able to provide you good medical care?
Thank you for the question. And I think in my experience, I didn't encounter that, because initially before COVID-19, I didn't feel that patients were resistant to it. It's all about the proper patient selection.
Yeah.
Who would you have for telehealth? Who would be able to use the telehealth? But most of these patients were patients I had seen in the office and before, so they were familiar with me. And most of the visits were visits that were mostly to discuss lab results or to discuss imaging results. So actually, they were very grateful that they didn't have to drive 4 hours from a different state or so forth just to have this discussion. So I think if patients understand that what the purpose of the visit and the objectives of the visit are clear to them, they're happy to stay in their own homes. They don't want to drive 4 hours. And even if you're in an urban area, they don't want to be like struggling to find parking and so forth. So I think understanding what the visit is about, because sometimes even in the office, they ask like, I'm not sure why I'm here. They need to know why they're there. And post-COVID, I actually also found that patients were very grateful. They were very happy to have a physician talk to them, and that they're able to discuss their problem with them. And they're also very grateful that we're able to see their homes. As Dr. Downey was saying, it was a very surreal experience for us to actually, they are able to see my office, I'm able to see their home. It was much easier for me to go over their medication. If they were not sure about the medication, they would go and get their medications, and they would show me on the screen, and we would do the medication reconciliation and verify it. So to answer your question specifically, I think patients are more digitally in tuned, and this will not work with every patient, and we have to be very clear on patient selection. And we also have to be quite clear why we're doing the visit. Like, why am I doing this? Clearly with COVID-19, nobody wanted to come into the office, but post-COVID-19, the purpose of the visit has to be clear. And there is value there, much more than the physical exam. A lot of times it's the history that we get from the patient that really matters, because you're ordering a lot of tests, you're getting an echo, you're getting an MRI. There are other tests that would assist your physical examination. And I think in the future, our visits are not just going to be without a semi-examination. There will be other tools. The enhanced visit will probably take place. There will be sensors. There may be some facial recognitions. There'll be other tools to assist, to improve the quality of the platforms in the future.
I agree. That's what I was doing for the last year and a half. Was at the end of the initial visit, I would tell a patient, so we are going to do, for example, an echocardiogram. We're going to do a treadmill stress test. And by the way, we offer virtual visits so that you'd be able to, from home or from work. And I had even patients who were in their car, and they would stop somewhere, and then we would, Well, actually, a couple of them were on the highway, but it turns out they were their passenger, not the driver. So I'm like, okay, that's fine. But it's, again, it goes back to efficiency and simplicity of the technology in of itself. Dr. Downey, so when you were showing your numbers, you had almost about 300,000 visits a year or so forth, 60+% were Medicare. What do you anticipate, I know it's hard, but what do you anticipate for the future regarding how this is going to go about?
Obviously, I can't read the mind of the federal government and how they may, what of these regulatory barriers they've taken down that they will choose to put back up. My sense, and I think this is a sense of many, is that the genie is out of the bottle to some extent for this. I think it's going to be very hard for them to go back and say, well, we're paying you $14 for a video visit. Or I think my guess is that telephone parity will go away and they will require video to get paid much. That's a guess, not any inside knowledge. I think video is likely here to stay. Whether it ends up truly at parity with face-to-face visits, I think remains to be seen. For Medicare, I think for other third-party payers, it very likely will. Blue Cross Blue Shield and Aetna and Humana are trying to sell to employers, just like we will directly sell our product to employers. What does an employer want out of a healthcare provider? They want the healthcare provided as inexpensively as it can be accomplished with minimal lost time for work. If I need to see somebody for their coronary disease, and that takes them 20 minutes logging in from their desk over from their office versus taking the afternoon off to drive an hour to see me for the same 20-minute visit, to then drive back home and have missed the whole day. Well, now the employer paid the same thing for the visit, but lost a half day's productivity from that person. I think that's ultimately going to be a significant selling point. That obviously doesn't completely apply, doesn't apply to the Medicare population. But my sense is that COVID is not going to be a 3-month phenomenon. This is going to be here for a while. What that means, I don't know, but I would be surprised if we weren't still in a similar boat a year from now. That means we'll be 14 months plus into an environment where the safe thing to do is virtual visits. Once the field has moved that far and patients are used to doing it for 14 months, it's very hard to see it going totally backwards. I'd be interested to know what others think.
I agree with you, Dr. Downey. I don't think we're going to just reset the button to pre-March 17th or March 6th when the law was passed. I don't foresee that. I think it's here and it's going to be here to stay. And CMS, and again, I don't have any insider knowledge, CMS had already shown that it was moving in that direction. They were reimbursing for some visits, the virtual check-ins. They were loosening the rules somewhat. And so, the fact that they moved very quickly and they were very agile about advancing this waiver, I don't see us moving now. There may be some regulation, there may be some measures that need to be put into place to ensure that, that there is value and safety in these visits, and proper documentation for most of these visits. I'm not sure about the telephone, because there remains the question of that not everyone has a smartphone. There are a lot of disparities, and it's been accentuated, or patients who don't have broadband, rural areas that don't have broadband. So the phone, I have a feeling that may stay, but of course we don't know. And we may be in this for the long haul. It may be a couple more years before we even know where we move. But at least it gives CMS some time to think this through after this rapid implementation.
Yeah. I think one of the rules on virtual medicine before COVID was being in a rural area or being or a certain distance from a major metropolitan city. I anticipate that the telephone visit may require something of that sort. I don't know how they would be enforcing that or how they would be evaluating that, but it's clear that there is definitely a disparity, socioeconomically at least. We've even seen it in education at this point in regards to the availability of broadband internet access. So let me ask a couple of questions that we have. I am in private practice, and how do I implement telemedicine if I'm not a part of a major or large institution?
I would say at least the platform we use is actually not made for a major organization. They are, it is an individual provider contract. We just did 222 individual links, and it's a, I think $35 a month subscription. Anybody can do it. It literally, you sign up online. It's easier than buying a pair of socks on Amazon.
And I agree. I mean, it's not cumbersome as implementing the EMR, which is very costly. There are many different platforms. I think the key is that these platforms are HIPAA compliant. I think that's the key. If it's a HIPAA compliant platform, that's what you want to invest in. You don't want to invest in something that's not HIPAA compliant, because if they're going to loosen, if any rule will be enforced, it'll probably be the HIPAA compliance.
And I think many of these platforms are a month-to-month subscription that is, a trivial amount of money in the grand scheme of things. But the fact that it's month-to-month means that if you make a mistake or something better comes along, you're not married to anything. It's just a website you visited and paid a subscription. That's frankly, less than the cost of your newspaper.
Yeah.
Another question that came up is, what would I not use telemedicine for?
I mean, before COVID-19, I would say end-of-life decisions, difficult discussions I would have never had to do over telemedicine, and it would not be my practice. Under the lockdown situation, we've had to have discussions over the internet. So the rules depend, what can and cannot be discussed depends on the situation. If it's a difficult discussion that you want the patient to be there with their family, and you feel that it needs to be face-to-face, then it has to be face-to-face. But if you feel that it can be done on the internet, then that would be adequate. I think it's end-of-life decisions, difficult decisions. Multiple, like talking to somebody about their 5th surgery that they need. I find it very difficult to discuss over a platform, but under the situation, we've had discussions.
I think the other piece is where there really is a critical physical exam component, they can't be substituted. There frankly aren't that many of those. I think vascular medicine, being able to feel pulse is important. On the other hand, it can be arranged that you get some testing ahead of time and make that portion of the physical exam relatively irrelevant. I think, the patient, it could lead to some increased testing. For example, the murmur that you might have left, but you get an echo because you can't hear it, but it was referred to you for the murmur. A little bit, to be honest, the majority of those patients are going to come to you with an echo for their murmur, not this is just a patient with a murmur. So I think the liabilities there of excess testing are modest, though non-zero. For me, the bigger one is one, the relationships and difficult conversations that Dr. Wassif spoke of. And then two, if they're coming in for a test anyway, if they're coming into my office for the echo today, well, probably I just to see you while you're here, rather than you drive home and we talk to you virtually tomorrow. I think a lot of the in-person visits we've done have been, well, shoot, you're already exposed in the same office. I might as well meet you there as opposed to hiding 10 feet away in my office.
And the other thing is that if it's a condition that I'm not able to diagnose through a telemedicine, and that has happened with a few patients, you try to troubleshoot during that visit and they come to your office as soon as it's possible. As a matter of fact, that happened a couple of times where patients with particularly shortness of breath, you're not able to assess their volume status. You're not sure what is going on. And those patients, I eventually had to bring them into the office to examine them.
So another question which I think many physicians are finding out very quickly, burnout. Physician burnout in regards to outpatient care and so forth. What are your thoughts about burnout? Clinical burnout from physician standpoint.
I think the burnout comes from the excessive messages and the EMR, and you spend your majority of the time in clinic, first documentation, and then you spend the rest of the week trying to answer questions and respond to the EMR message. That's part of where the burnout comes. And I think part of it as well is sometimes the lack of efficiencies in our clinic, the flows. Some things don't flow very well and so forth. And where telehealth is somewhat helpful is that there is efficiencies built in it where things are done ahead of time and you just essentially show up and do your visit. And the documentation may be the same, but there may be other tools that would help with the documentation. So the burnout, I think, is a major issue, and we're all suffering from it. And I don't think there's a magical bullet to treat it or a magic pill to treat it. I think efficiency may help it.
Yeah, I think it would be a mistake to pretend like this is a panacea for the challenges of burnout. It's simply another tool for doing the same work that we've always done, with most of its flaws, with most of the benefits that we also come to work to provide for our patients, but many of the efficiency flaws that have contributed to burnout. I think you saw on our graph that we are still at only about 65% of our usual weekly volume in the outpatient clinics. The reason for that is recognizing the challenges of this transition as we've switched our follow-up visits from being 15 minutes to being 30 minutes. And we've kept our new patient visits at 30 minutes. You still work the same number of hours, but you're only getting about 2/3 of the patients in a given day. That helps with burnout, but ultimately leads to only 2/3 of the visits across the week. That was, I think, an important thing to do to facilitate adoption and help people get over the hump. but I shouldn't pretend like it's a panacea for burnout. And now, with that said, I've had a couple of providers say, you know what, I had clinic today, and I did it from my back porch via video, and it sure was kind of nice being at home with my wife and doing it from my back porch instead of in a windowless office.
Mm-hmm.
I don't know that that'll really last, but if that were one day a month, I think that actually helps a little bit. But it by no means is this a panacea.
No, I definitely agree. I think eventually, once this kind of settles down, it will become some sort of hybrid type of situation where you have 1 or 2 days a month where you can actually do most of your visits from home, do most of the digital paperwork from your EMR system from home or so forth. But no, I definitely agree. But I also think that eventually, if and when this becomes a lot more mainstream, meaning that we have proper devices, proper data, if we have the data in regards to activity, blood pressure, heart rate, weight, and so forth, and proper and accurate information regarding medications, and questionnaires beforehand, so you know what this visit is about, it makes the 10-15 minute time with the patient a lot more efficient.
And I see that I do believe that telemedicine, these visits are more efficient than the in-person visits. You're cutting on a lot of inefficiencies that you may face in the system, the delays that happen in the system. I believe that here the clinic, to a certain extent, goes much, much smoother with no delays for the most part. And that reduces the burnout. I mean, it certainly does. It's not a cure because it's only one aspect of the reason why why physicians are burning out, and it's not only about the clinic.
I'll say I have a lot more or a lot less late shows and no shows on virtual clinics. There's no reason for it.
No late patients.
Driving into the Texas Medical Center and trying to find parking and trying to figure out where the office is and so forth, and they come huffing and puffing trying to get there. It's a lot more comfortable, a lot more easier to be on time from home or from work.
Exactly.
Well, I would like to thank you both very, very much. It is a pleasure to have you. As I would like to thank our guests, Dr. Heba Wassif and Dr. William Downey, as we conclude our session today. Thank you so much.
Thank you, Ahmed. This was a delight.
Thank you, Ahmed.
Thank you.
Done.
In the upcoming sessions, we'll be discussing many other aspects of digital health and telemedicine, including presentations about coding and setting up different types of platform, including possibly curbside virtual consults, how to start implementing new training processes for our fellows and medical students, and many other ideas. I'm grateful for the opportunity to direct and host this series. Please consider leaving us a review on our webpage or YouTube channel, and mention any other topics you would like us to consider discussing in the near future. Thank you very much.
Thank you.